So I'm asked to talk about managing fiscal devolution to protect health investments and to promote interstate equity, lessons from the Philippines. We have been implementing devolution for the last 22 years. So my outline is to be a short history of the devolution. It's also called decentralization in the Philippines, the fiscal challenges faced during that time, and of course the policy recommendations, which I hope could also help India in its managing the devolution, because it was only quite recently compared to our 22 years of experience. So I'd just like to note some of the key terms which you might be familiar, because here you have the ministry system while we have the department. And LGC, the Local Government Code, was the defining law that mandated devolution across the country. And of course, we talk of LGUs as a generic term to describe the provinces, municipalities, cities, and villages. And COA, our Commission on Audit, plays a lot of role. And of course, PhilHealth, our National Health Insurance Corporation, and the Department of Finance and the Department of Budget and Management. So some milestones: we passed the Local Government Code in 1991, and also a National Health Insurance Act creating the National Social Health Insurance Program, now known as PhilHealth. And another one is, of course, in 2010, our President Benigno Aquino, our current president right now, declared universal health care for all Filipinos as the major health policy thrust of the Aquino administration. And he was so far the only president that included health in his development agenda. And of course, in 2012, we had a very significant, again, also thanks to the lobbying of our president, that there was increasing taxes from alcohol and tobacco for exclusive use of the universal health care. So that generated around $2.2 billion US, and again, enrolled 35 million of the poorest and the poor in the Philippines in the social health insurance scheme. So just to show you the magnitude of the devolution, well, at that time, very centralized, but we had, of course, personnel, total in the Ministry of Health, 78,000, but we had to give away around 46,000 of that. And in terms of money, we had to give away to the local governments around 4 billion of our 10 billion funds. And again, all hospitals, except for around 80 hospitals, have been devolved to all provinces and cities. So let me just show you, there are, of course, inequities in the Philippines, where we have 25% of the population, where 100 million, roughly 25% are living below the $1 a day, and another 15 million. That's what we call the poorest, and now the poor are really those who live on $2 a day. So that's the scenario in the Philippines. So first, the resources of the country through taxes, national taxes, was called the internal revenue allocation. And there was uneven distribution among the provinces, cities, municipalities, and villages. Cities and villages actually gained more from these funds. And there were losers in the devolution. Those are mainly provinces and municipalities, because they were asked to bear almost all of the health expenditures. Well, the many health expenditures that they need to do, but this was not enough compared what the cities and villages had. At that time, the villages never had a share of the national taxes. And this is the first time, and up to now, all 42,000 villages in the Philippines are allocated taxes from the national funds. So not all local government units are giving resources to health. So as of today, only 50% of local government units are truly investing in health. We have a scorecard wherein we monitor this throughout the years. And then the salaries of local government health personnel are lower than the nationally hired health personnel. So these are the inequities. Now let us look at lessons learned, and this is where India may be able to gain much from your scenario as well. So again, lessons learned, the poorest and poor municipalities and provinces are unable to fulfill health responsibilities of devolution due to their own resource constraints. Our recommendation, of which I did during my term as minister, was we created a national health equity fund with the approval of our president at the time, Fidel Ramos, to assist all LGUs unable to bear cost of devolution. However, after my term and after the presidency of President Ramos, this was not followed by the next two presidents, okay? Except now, again, the present president is giving it more attention. So it's very important to have political will along that line. A second lesson is that we had disintegration of coordination and referral systems between municipalities and provinces and between provinces and cities and the national. Literally, up to now, we have not really recovered from that. The referral system is far from the ideal, and appointments and promotion of health personnel by the local government have been politicized, unlike when it was in the national level. So our recommendation is make all municipalities under the health administration of provinces. Well, the devolution of the the internal revenue taxes will continue, but however, our recommendation in the health sector is that the municipalities is not fully devolved in health alone, but they should be part of the province to have a coordination, particularly in referral system. The provinces also to appoint and supervise municipal health officers and supervising nurses and midwives. This will lessen the politicization of the appointments and promotions, as well as a mandatory creation of district health systems and governments. Remember, the district health system were destroyed during the devolution because it was not part of the original design. Municipalities were autonomous from the provinces, and ergo, there was really no intermunicipality nor even the province. But through the Ministry of Health, we did some circulars encouraging. However, the results are not good, meaning only 50% of districts have been restored. Again, the third lesson, salaries of devolved health personnel are way below the national salaries of nationally appointed health personnel. And we do have a salary standardization law in the health sector, and assistance can be charged to the Equity Health Fund. And right now, because of the enormous income from sin taxes, my suggestion is now, well, the sin tax only the last 3 years. We also gain an additional $2 billion from the sin taxes. So the income from this can be part of the subsidy of the national government to those who are unable. By the way, in our devolution, only the cities were able to standardize the salaries at match and even sometimes better for the rich cities. So again, our fourth lesson learned is the fund reimbursement and capital fund of the National Health Insurance for local governments are unevenly utilized for health investments by provinces, cities, and municipalities. This national health insurance money come into the local governments in the form of capitation, as well as reimbursement for their expenses for members of the national health insurance. Our recommendation is, of course, a fiscal autonomy for local government hospitals and health centers and other facilities. Fiscal means because they're under also the manipulation of governor or a mayor that is not committed to health. and such income to be used solely for health investments. Again, this is quite difficult given the autonomy in fiscal situations in most of our local government units. Again, the Commission on Audit, the Department of Finance, and the Department of Budget and Management should create their own administrative circulars to guide local government units to apply incomes from PhilHealth solely for health purposes. So this will probably enforce that this income from the National Social Health Insurance will truly be used for health and not for any other. But this is what usually a mayor or governor thinks he has a right to use it for other things. The fifth lesson is that only 50% of our local governments give priority to health investment, despite increasing transfers of funds over the last 22 years by the Department of Finance and Department of Budget and Management. Again, the term is the internal revenue allocation. Our recommendation is that national grants to local government units solely be made available to LGUs that comply with key investment and health planning criteria. Meaning to say that the first peso is on the local government internal revenue allocation, and the national government will tap this if the local governments perform and show that they are truly investing in health. With, of course, visible results as outcomes and impact on the health of the population. So again, it is as of now, because of the devolution, the Ministry of Health has limited visitation rights and to do audit of health services and promotion policies. So use of these national funds, resources, and overall health management processes should also allow the Department of Health or Ministry of Health to do some supervision, if at all, to the local governments. Well, this is my last slide because what are the more essential things that I have not mentioned but are very important in fiscal devolution as well as overall decentralization of the health system? The establishment of a universal social health insurance fully supported by national taxes, preferably from tobacco, alcohol, and this year, in the next 3 months, we are going to pass a sugar tax, meaning to say to lessen the impact of processed sugar and high fructose corn syrup. They'll be taxed more, particularly in drinks and even in food that are already processed and prepared. Again, the sugar tax is estimated to give another $1 billion in taxes every year, and it will be increasing over time, just like the tobacco. The tobacco and alcohol taxes are still increasing over the next 10 years. Community-based health programs with community empowerment, community participation, and community involvement for increased health promotion, prevention of diseases, and primary health care. Unfortunately, our last two presidents in the past totally abolished the structure because they truly want centralized power once more in terms of political decision. However, this has been a feature really during the time of President Aquino and President Ramos, truly in the spirit of genuine devolution and participation. And lastly, this is what we lack, but I know India, probably we can learn a lot because you are more proficient in producing digital information in health, but we never had it. So installation of an e-national health information system for monitoring, evaluation, as well as redesigning the health system. The digital network must be from national to provincial and city to the municipal levels and should be available to the village community levels. This is very much possible because 85% of the Philippine population, including the poorest and the poor, have cell phones. However, cell phones, digital technology has not been used for health the way other countries have done it.